Welcome to the University of Washington Tracheotomy Care Training video, module on finger capping, button capping, and talking around a tracheotomy appliance. By the end of this video, we anticipate you will be able to explain the rationale for capping a tracheotomy appliance, demonstrate finger capping and button capping, describe the contraindications to capping, explain the purpose for, use of, and contraindications for using a speaking valve, and describe the indications, contraindications, and steps for decannulation. A cap on a trach tube fully blocks the airflow through a tracheotomy tube and restores respiration back to the usual flow through the nose and/or mouth. Capping a tracheotomy appliance can also enable air from the lungs to pass up through the trachea around the trach tube and up through the voice box to create sound. Another advantage of capping is that when a trach is covered, humidification is not necessary because the air flows through the nose. Likewise, suction is not usually needed as long as the patient is strong enough to cough out secretions. If a patient can tolerate a long period of capping, he or she may no longer need their tracheotomy. In order for trach capping to be successful, there needs to be enough space around the trach tube for air to pass easily. This means the tracheotomy appliance needs to be small enough and the patient's airway has to be big enough to allow air to pass. If there is too much swelling of the airway tissues around or above the appliance, there may not be enough space for air to escape above the trach. If this happens, carbon dioxide can build up in the lungs and lead to acid buildup in the blood. Shortness of breath, fast pulse, headache, confusion, and sleepiness can follow. One of the simplest ways to test if a patient may tolerate capping is to perform finger capping. To finger cap, the provider or patient places a finger over the trach tube opening to see if the patient is able to breathe and speak around the trach tube. Here are the steps. Ask the patient to take a deep breath while the trach appliance is open. Have the patient place his or her own finger on the trach opening, and see if the patient is able to breathe easily in and out while the finger is in place on the trach opening. As they breathe out, ask them to try to say a word like hello. Remove the finger from the trach opening so the patient can breathe comfortably in and out again. If they can tolerate finger capping comfortably, they may be a candidate for the use of a speaking valve. The speaking valve is a one-way valve that allows air to go in through the trach tube but seals it up from behind, thus forcing air to go upwards through the larynx, allowing a patient to speak. The major advantage of this over finger capping is that it is hands-free. Most speaking valves attach to the front of the tracheotomy tube. There is an additional type of speaking valve that is placed in line with the ventilator circuit. This is typically used in patients chronically on a ventilator. An additional benefit of a speaking valve is that it can help the patient control the pressure between the outside world and the patient's throat and airway. This can assist with coughing and swallowing. An important criterion for allowing a speaking valve to be used is that the patient must be awake and alert and able to remove the valve easily if they are having difficulty breathing. If a patient is unable to remove the speaking valve him or herself, it should only be used with supervision. When a cuffed tracheotomy tube is used with a speaking valve, it is very important to verify that the cuff is deflated and that there is adequate space around the cuff. Use of a speaking valve with an inflated cuff can prevent air from leaving the lungs, which can lead to carbon dioxide buildup. If a patient is able to successfully breathe both in and out while finger capped, a medical provider may recommend a button cap. It is important that the patient is medically cleared for capping. A button cap often comes in a package with a trach tube. Some caps are part of a special inner cannula. It is very important that the patient know and be able to remove a cap. If the patient cannot remove the cap on their own, then they must always be supervised when they are capped. It is important to only cap during the day and not to cap the trach at nighttime or when sleeping, unless directed by a medical provider. Button capping should never be performed with a cuffed tracheotomy tube, whether the tube is inflated or not, because of the turbulence of airflow around the trach tube. Decannulation refers to removing the trach tube completely. This is performed when a patient no longer needs the trach tube. Capping trials are often done prior to decannulation to ensure that it is safe, although of course this cannot be predicted 100%. Generally, a patient will start by capping during the day for a few hours at a time. Once they are able to cap comfortably for a few days without removal, the patient is generally a good candidate for decannulation. In this module, we describe tracheotomy capping, speaking valve use, and decannulation, including the appropriate procedures, their rationale, and cautions.